Oh, I don't know as many names.
All right, our next speaker is going to be Dr. Janice Gomersall. Dr. Gomersall is a family practitioner here in Missoula. She also is currently the medical advisor for the Disease Management and Nurse First program for Montana Medicaid, which is administered by the McKesson Health Solutions. We've had the opportunity to work with Janice quite a bit and really work with the Nurse First program and the chronic pain disease management program, and I really think it's going to be a huge benefit for managing some of these patients that are very difficult in terms of getting them the care that they need. So I'm interested in hearing her experience with this program and really taking a disease management approach to chronic pain, because I really do think that that's probably the future if we're going to make any impact in this disease process. So, Janice?
Thank you. I really feel like I'm in a unique position because I am a primary care provider. I'm a family physician. I see patients, both Medicaid and non-Medicaid, but I see all the different patients and I have to deal with acute pain and chronic pain. And I also have a psychology background, so I understand a lot of the cognitive behavioral therapy and some of the issues that really play in with a lot of these patients. What I think is really interesting about the conference so far is that, we've heard lecture after lecture and we're all on the same page. Everybody has a few of the same slides in their presentation, and we're hearing from national experts as well as local people. And this isn't what it was 5 years ago. It's not what it was 2 years ago, where we were attending lectures on opioids, and that was it. This is really advancing, and I think Montana is in a unique position because we have a lot of people who are interested in advancing the whole field. The other part is because I work with the Medicaid program, in Montana, this is one of the very few states who actually treats chronic pain as a chronic disease, just like asthma, just like diabetes. And they had the foresight to do this. We started it May of 2007, so it's been going on for about a year and a half. And I think we should be really proud of Montana that they have thought about this ahead of time. My talk today, I really wanted to break it up into 3 different sections. One is basically making sure everybody understands how people think throughout the world about chronic pain as a chronic disease and how it used to be thought of and how some people still think about it, but how we ought to change their opinion. So I have a few quotes and a few information about that. Also, building a little bit on our cognitive behavioral therapy and looking at the patients and seeing which patients work better in trying to intervene, really trying to see if we can sort out this a little bit. Again, it's a 30-minute talk, so we're not going to go through it too deeply, but I just wanted to give you some tidbits on that and go through a few studies on that. And then lastly, let you know what the Montana Medicaid program is doing with the Nurse First program, both in other diseases as well as specifically how we have utilized all of the research and specifically the kinds of things that have been brought up this morning and how we're using that in our program. Something that I came across, and I know we have a lot in the United States, but I thought this was interesting, that in Europe they had the conference in 2001, and they came up with a declaration, they came up with a statement, and they came up with reasons why they wanted to talk about pain as a disease and why pain needs to be treated. These were the issues that were thought about while they were coming up with this declaration. And basically, these are why we think it ought to be a disease. Initially, persistent pain can come up with a life of its own. And if that's true, that's probably something that really ought to trigger us to think about it as a disease. There are plenty of different diseases that have characteristic symptoms, syndromes, and things like that. Chronic pain, we've seen slides about all the different psychosocial things that are involved, the physical things that are involved, and maybe that's where we ought to be thinking that chronic pain is a chronic disease. And then lastly, there's a lot of arguments about other different diseases that are chronic, hypertension and depression and psoriasis and arthritis and things like that. Chronic pain is a chronic kind of a disease. These three issues were what was raised by the European Association, and that's why they came up with the declaration. I also went through, and as I would do some of the readings and do some looking up, there's lots of definitions for disease. And as you read through these definitions, does it sound like it would realistically incorporate what chronic pain is? The Oxford Dictionary talks about functions that are disturbed. The Encyclopedia Britannica talks about how disease interrupts or modifies vital functions. The Medical Dictionary, Stedman's Medical Dictionary, talks about perversion of function or interruption of function. And again, this morning we've talked a lot about how chronic disease really affects your life and how it affects what you do in your daily functioning. Why in the past have we not considered it a disease? I thought the first one was really interesting. Is it just our habit that we consider pain like fever or like a symptom, a diarrhea or something like that? Is it really something that we need to get out of the habit of thinking of it as just another function or another symptom? I did think it was a little interesting. We do use pain as the fifth vital sign. So we have thought about that. We're supposed to be using that as the acute pain. I have a funny story about, and this kind of reflects what we've talked about this morning. I had a patient who was relatively confused. I was admitting him through the emergency room. He had lain on the gurney for quite a while, and in every room, in every hospital now, there's the vital signs of pain, and it's hanging on the wall and says 1 to 3, and it has the smiley faces or the sad faces. And he proceeded to let me know that, you know, when I'm a 6, people aren't very happy with me. And when I'm a 10, they're really mad at me. And so that's how he was reading that. And when you think about it, when you talk about chronic pain and the emotional milieu of what's going on, that is true. You know, if you're not getting along with everybody, you're a 10. And when you're sort of getting along, maybe you're a 6. And everybody loves you, you're a 1 or 0. The second point is basically we used to describe pain as, okay, you had appendicitis, we fix your appendix, you don't have pain anymore. You have a broken arm, we fix your broken arm, you don't have pain anymore. And we've kept thinking that even with chronic pain, and that's why we haven't thought about it as a disease. But as we've heard this morning, that's not really true. And lastly, with psychiatric diseases, we perfectly recognize that there are lots of diseases out there that we can't do a blood test to diagnose, we can't do a CT scan and diagnose, we diagnose it on behaviors. And that's what chronic pain is. There's a lot of behaviors that are associated with it. And so in that sense, we really ought to be not discounting it because you can't measure it or you can't CT it. Here's the declaration, and this is, was presented in 2001 at the European Parliament. And it's basically, although acute pain may reasonably be considered a symptom of disease or injury, chronic and a recurrent pain is a specific healthcare problem, a disease in its own right. It took them until 2001 to decide that, but we reported it here in 2004. Again, this is a very similar slide to what we've seen in 2 previous lectures this morning and this afternoon. Basically, the kinds of physical and psychosocial changes that are associated with chronic pain. And even if you have 1 or 2 of these, you see how it really does affect your functioning in life and how your life is working. Prevalence data, I have some slides in here with a lot of statistics. Some of them are a little out of date, but I thought I would use those to illustrate how things have changed. The prevalence of chronic pain, when you ask people, at least half the people will say, yes, sure, I've had pain. Probably higher than that if you ask the right questions. The most common chronic pain conditions, low back pain, arthritis, and recurrent headache. The Montana Medicaid program covers 5 chronic pain conditions. These are 3 of them. And the last comment is, again, the same one as, you can have pain, but you don't have to suffer it. Few people die of pain, but many more live in pain. Social costs, we had in Dr. Dahl's presentation this morning, her slides that Dr. Rudin presented, we had some graphs about some of the social costs of pain, job absenteeism, workers' comp data, things like that. And basically it really is a big issue, and it's financial, but it's also loss of productivity and things like that. Some of the financial ones, if you look at the U.S. or in the world in general, it's 2 to 3% of the gross national product. If you look at the U.S. per se, now these are 2004 data. We saw some 2006 data on some of the slides this morning, and that was double. So instead of 50 million having significant chronic pain, 100 million do. Still 50% of them have the acute pain, and that's, I have 50 million and 25 million. But the 2006 data, and I'm sure the 2008 data would be higher. Now, I'm not sure if that's in better statistics or if it's that we're actually getting worse. We have some ideas that sometimes the reporting of pain is worse because of the social and emotional aspects, and therefore people report it higher. Okay, my second section is more on the treatment and in specific pain management and putting it into disease management. Pain management needs not to just treat the pain, and we've heard that. We don't need just opiates. We need to look at the bigger picture. We need to look at the person as a whole. We need to look at the biopsychosocial model. We need to look at the consequences in their life, and specifically that the emotional factors probably play the biggest factor in everything. These are some of the big points that I guess I feel most passionate about. You need to look at all the factors that are involved. And Dr. Davis presented how he questions the patients and asks those different things. And I think I was starring everything he's saying, and I'm going to get those articles because I want to see those questionnaires. I want to see how they're asked. And I think part of what I do when I refer people on to specialists or to the pain center is hoping that they'll get that full history that I'm not really getting from the patient, and ask it in a way that it becomes useful information. The second point is that I don't refer specifically to interventionalists without first asking all those different questions. Now, I'm a family doctor. I can ask those multidisciplinary questions. I can do a little tiny bit of cognitive behavioral therapy. But if I wasn't comfortable with that, I think I would only want to refer to a multidisciplinary team that could start out fresh and ask all those questions. When my patients come back and they said, they want me to go to 9 appointments, and I said, good, because then you're going to get that much care. Unfortunately, in Montana, we really don't have access to multidisciplinary centers all throughout, and that's a problem. Thirdly, look at the kinds of therapies that improve function. And fourthly, we need to really push for research, for more resources to be able to actually do what we need to do. In terms of disease management per se, disease management programs really have to look at the patients who are going to be treated the best. Most disease management programs from both the commercial and the government programs need to save money, and that's what their goal is. So they need to look at which patients are the ones who are the most impaired and which ones are the patients that are going to get the most benefit from the programs. We need DM programs that promote guideline-specific care. Now, there's lots of guidelines out there, and I have an article a little bit further that talks about using guideline care and promoting it to primary care physicians, and how did that work. We're not very good at that. And then, most importantly, have a medical home. If you talk to a patient and ask them, who's the doctor that takes care of your pain? The patients who have a name to put with that do the best. The patients who say, I don't know, I go to this person for this pain and this person for that pain, they're not going to do as well. And specifically, the Medicaid program pushes that they have to have a medical home. Works pretty well in Montana because we have a passport program, which 80% of the Medicaid patients are on that, and they have to have a primary care doc. Doesn't mean their primary care doc is the one who is actually doing the pain management, however, but sometimes it is. Okay, a couple studies. This was a chronic pain DM study, and this was specifically to look at how does a DM program specifically work for pain management. The three aims of it was, first, can you identify which patients need to be treated? Second, did this work on the clinical practice? And third, how did the providers like it? Okay. Basically, you identified the patients through claims data. Then they used two surveys, the SF36 and the pain impact rating scale, and I'll go through those, to see who was the most impaired and therefore who would benefit the most. And then the physicians were given a workshop, they were given algorithms, they had 24-hour access to help, and then they did a questionnaire afterwards. The two surveys that they used, the pain impact rating scale basically looked at 21 items. They looked and asked the patient specific questions about severity, and they said the persons who had the highest scores were the worst off. They had the highest pain intensity, activity interference, emotional stress, poor social support, and poor history. They were looked at as the greatest risk and therefore the ones who would probably benefit the most. The SF36 is a health status questionnaire. There's an SF36, an SF12, and SF8, and each one has just kind of honed it down to the more specific questions. This one was specifically targeted to use in clinical practice and research. It looks at 8 different concepts. The highest score on this means you're doing the best. So you have better access to social support. You're not limited in your activities. So basically, those who had the highest composite scores on the pain impact rating scale and the lowest scores on the SF36 were the ones that would benefit the most. When they asked the providers how they did, they said, well, this was great. We really like this information, but can't you make it simpler? We just can't follow these big, long things. That just doesn't work. And they also thought that the DM program would definitely help. They just needed more help on it. Other scales that are available, we heard a few this morning and this afternoon as well, but these are a couple other ones that I looked up on. This was a study of 5 of those questionnaires. They looked at all these different questionnaires and tried to find which ones were the ones that could really pick up change. So if a patient was evaluated first and evaluated at the end, could they pick up a change in, say, a 4-week time period? Of those, the MPI and the SF36 were the best. The Montana Medicaid program uses the SF8, which is a modified version of the SF36. Then they also looked, this is a different study that was done in 2007. This was looking at if you call a patient up or if you send a patient a questionnaire, which one works better. And now, of course, there's a cost differential between those. But this was a randomized controlled test. It was a crossover. What they did was they gave them the survey and then they gave them another survey, the same survey, but in a different form. And pretty much they got the same results. The telephone results were more expensive, but they got more complete data. And the only thing that was affected by letting them take this test first or this test first and then crossing over were mental status questions and basically memory and things like that. The Montana Medicaid program pretty much uses the telephone surveys. Okay, and then this is more of which patients would benefit most from a DM program. This was a fibromyalgia study. It was a very small study, but there are many other studies in the literature that reproduce this kind of an idea. Basically, they looked at patients, they did a questionnaire at the beginning, treated them, and then looked at what the outcome was. They used the MMPI. There were 3 categories of patients. The dysfunctional patients were the ones who had lots of pain and very poor coping abilities. The interpersonally distressed ones were ones that were having relationship difficulties, and the adaptive copers were the ones who actually were doing okay. They didn't have that much pain, and they had a good social system in place. When they looked at who did best, the dysfunctional patients did the best. And basically, that's because they taught them how to cope. They worked on the problem that they had, which was causing more pain. The interpersonally distressed subjects didn't do any better because we can't fix them. We can't fix their marriage. We can't fix their job. We can't fix their boss. And so there really wasn't anything that was helpful to them. And the adaptive copers were already doing so well that we really didn't make a big benefit. And therefore, when you do disease management programs, you want to look for the dysfunctional patients. You want to look at the patients that you can actually make a difference, and that's how you're going to get more bang for your buck. So, in summary about these, basically, we've heard about this already today, that those who can recognize the psychosocial variables and treat those, we're going to have better effect. The questionnaires that can pick up on those are going to be the most helpful. It's important to think of chronic pain as a chronic illness, and the multidisciplinary treatment programs are probably going to do the best unless you can actually do it yourself. And as we heard just by Dr. Davis, the increased independence and restoring them back to their physical and social functioning is really going to get you a lot further. Okay, let me give you a little bit of information on the Montana Medicaid Nurse First program. Basically, the main program covers Medicaid patients. There are 2 components. One is the Nurse First Advice Line, and this is a 24/7 advice line that all Medicaid patients can call in anytime, ask questions. They call in when they have a cold. They call in to figure out, should they go to the emergency room? Should they take care of something at home? The nurses who answer this 24-hour line are all licensed in Montana. They basically take the questions. The patient will call in and say, this is what I have. They ask them the questions. They go through an algorithm. They said, okay, what about this? And then it puts you to the next decision tree. And at the very end, they say, okay, based on what you've told me, I think you need to do this. And they'll tell them to either go to the emergency room or stay home or call your doctor in the next 24 hours or 72 hours or whatever. They don't really diagnose. They just kind of give advice. The second part of it is the disease management program, and this is also community-based nurses who are on the ground who go out and visit the patients, or the telephonic nurses. Right now, Montana has heart failure, asthma, diabetes, and chronic pain. Patients are identified basically on claims, whether or not they've been diagnosed with this by going to the emergency room or their primary care doctor. The nurses who contact them ask them, hey, what did your doctor want you to do? What medicines are you on? Are you taking them? They try to reinforce what the provider has asked them to do. They also help them if they need to get their prescriptions or get their DME or whatever they need to do so that they can comply with whatever the provider has asked them to do. Depending on how risky they are, if they are the highest risk, lots of problems, no social support, lots of ER visits. They get called very frequently. If they don't have too many problems, they only get mailings and a few calls in the year. All Medicaid clients are eligible, but if you're dual eligible, you have Medicare, Medicaid, then you're not on this program, and that's because this is a waiver program from the federal government, and we had to identify a very specific population. The providers can refer in, the patient can take themselves out. Nobody else can take them out, but the patient can. The reason we have this is because the state legislature said, hey, you got to save money. And their option was to cut the reimbursement or cut the services or find something else, and basically they found a disease management program, and that's how they decided to do it, and it has worked very well. Started in 2004, had a 2-year renewal in 2007. Okay, now some more specifics on the chronic pain part of the disease management program. Those who are eligible are over 18. They have one of these 5 conditions. The headaches, back pain, and osteoarthritis are the most expensive ones and the most frequent ones throughout the country, as well as Montana. Chronic fatigue and fibromyalgia are also on the program. To get on the program, though, there are two parts of this. One is to have a visit with one of these chronic pain problems. The second part is to also have a psychological diagnosis. And it doesn't mean you have to have depression. It just means that you have to be seen with something that was distressing. And that's how we were sorting through and finding those highest risk patients and intervening with those highest risk patients. We use the SF8, the short form, this is the slide you don't have in your packet, I apologize, but I thought you'd want to see at least some of the questions. You rate it on 1 to 5. In the last 4 weeks, have you had problems with this, 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 and this? How do you rate yourself? How much difficulty have you had in your daily work, physical, emotional health, things like that? We do it at the beginning, we do it at 6 months, we do it at 12 months, we do it at 18 months, and we see how they do. There's ongoing assessment. We don't just leave them alone. Some people get assessed every 4 weeks because they need it. Some people only every 6 months. 3 risk groups, stable, moderate risk, and high risk. Obviously, the highest risks are where we're going to make the most impact for financial. Barriers to good outcomes. If the patients keep switching docs, it isn't going to work. So one of the aims of the program is to encourage them to stick with one doctor or one provider. Again, the psychosocial issues, any kind of problems, the nurses help them with this. These are the kinds of things that we want to do. We want one provider. We want them to stick with their provider and do what their provider wants. We present guidelines. We have action plans for managing pain. If you want any of those, we have a booth out here. You can pick them up. That wasn't advertising. The main thing is to really teach the patient some coping mechanisms and find out what they need. Some examples of self-care: physical activity, positive self-talk, and relaxation. Sound familiar? Avoiding their pain triggers, identifying them, doing lots of different options. Smoking cessation is a really big thing. It really does help. And so every time we send them information on quit lines, we talk to them about it. So these were examples of self-care. These are examples of coping skills. Again, physical activity, positive self-talk, and relaxation. It works. That's why we do it. Also finding some good people to spend time with. Some support groups are really important. Okay, so far, it's a new program. We really don't have a lot of information on it. We don't have a lot of people who've been in it for 12 months, so we don't have all the last assessments. We've sent out pain contracts to providers. We've visited with them, let them know about it. We have the option of team care, which is the medical restriction program where if the patient has been seen multiple times in the ER, multiple pharmacies, on and on, they can be on team care and the provider can request that they are on that. And that helps them to kind of hone them in and require them to have one provider, require them to have one pharmacy. Call the nurse first line before they access care. It really doesn't take a lot of change in this team care population to be able to save a lot of money if they're spending most of their time in the ER, and we can avoid that. So basically, I put a different email address here. There's also one on the biography of me in the beginning. Either one works. Depends on how fast you want me to get back to you. Okay? Thank you.
Our next speaker is Nelson McGreary. Dr. McGreary is a doctorate of physical therapy who works at Community Medical Center with the chronic pain patients there. And I think that all of us would agree, and what we tell all of our patients who begin treatment at the Montana Spine and Pain Center is that it is absolutely essential for you to develop some type of an exercise program. Now, we're not trying to, turn everybody into Jack LaLanne or Charles Atlas. What we're really trying to find is something that patients can see themselves participating in for multiple different reasons. One is activity and motion is so critical to controlling chronic pain. The other thing is something that I learned secondhand from one of the students of Wilbert Fordyce, who pretty much is the father of chronic pain over in Seattle. And he had a very simple way of putting it. People who have better things to do don't hurt as much.
All right, thank you very much. It's a real honor to be here with such great speakers, people that are so interested in improving the quality of pain treatment. My path as far as treating chronic pain is kind of interesting, but I found that it's similar to a lot of people who work with people with chronic pain. I started out of school 12 years ago when I graduated from Washington University in St. Louis, and about 50% of the population that I saw was chronic pain. And I quickly burned out, about 2 years of that, and I was worn out. And I think it was because I didn't understand if I was being effective. I didn't understand necessarily what the goals were. And so it took me a while to take another crack at it. And I went back to school. I just finished my doctorate in physical therapy in December. Studied a lot about chronic pain, and as Dr. Sechrist said, went back to the science to try to help guide this a little bit. And although I wish I had $1 for every time I heard, well, with chronic pain you need really good physical therapy. When I've read the literature, it's sure not as clear from the literature as it sounds sometimes when people talk about exactly what is good physical therapy. And I hopefully will clear that up just a little bit. This slide here, the importance of a good night's sleep, I think it's good for two reasons. I think a lot of people are probably thinking about that right now. But also, Dr. Sechrist suggested that maybe we could come away with a few pearls here about, well, how could you help people that you're working with? And I'll tell you, there's not much you can do for people other than improve the way they sleep if they have chronic pain. If you have chronic pain and you can't sleep, it gets worse. And I think that the potential impact of what physical therapy can do to improve sleep and some other very common things is really underestimated. Now, as far as finding a good physical therapy experience, because I realize that we've got people from all over the state, and sometimes there's resources that are available and sometimes there's not, and so you've got to work at all sorts of levels. Well, I think that if it's at all possible, find somebody that's got an interest in chronic pain. It's such a different ballgame. When you work with somebody with acute or subacute pain, and the expectation is they're going to be better when this is done. It's all over when they're out of here. It's very hard to change from that thinking to the idea that this person, they're getting better, but they're going to have chronic pain for the rest of their life, in all likelihood, and we're just helping to manage that. It's a different perspective, and I've heard people talk about how in medical school there's not a lot taught about chronic pain. Well, it's certainly true about physical therapy school, and since the biggest reason people come to physical therapists is because of pain, I think it's a real crime. If you don't have somebody that can work with that works with chronic pain and has a huge interest in it, I think finding somebody that works with chronic conditions, or used to working with people, elderly people, for example, is a real good alternative. And so whoever you find, I think working with somebody and developing a dialogue over years can be really, really helpful. As part of this virtual pain team, The conversation between myself and the doctors, I think, really improves the quality of care as things go on. And so whoever you work with, try to develop a relationship, because if you're going to be caring for this individual for 20 or 30 years, it's good to have somebody that you don't have to start over with every time. And this last point here is that I think physicians and nurses, all sorts of people that refer to physical therapy can really do a great deal to help the situation by suggesting functional goals. We all see a different side of the people that we work with. And if there's certain things that we see, I think it's good to say, well, can you see if you can help this person sleep better? Can you see if you can work out getting out of bed, for example? I mean, these little things that aren't so little when they really cause a great deal of suffering. Well, as far as chronic pain goes, if you are a therapist that deals with this, you really have to come to terms with two ideas here. Chronic pain can cause individuals to attribute excessive risk to movement. And so by that, it's like there's an idea that perhaps if I move, things are going to be worse. Well, they're going to be worse if you don't move. Yes, you've just got to move, and one way or another, we've got to find a way to move. That's really where the risks are. The other thing is that this risk of this sense that there's this risk to movement can decrease the self-efficacy, or the sense that people can get things done in their lives. These are really what I see as the three essential factors as far as treating people with chronic pain in physical therapy. And the first is to educate. And one great luxury that we have in physical therapy is we have an awful lot of time compared to the physicians and the people that are seeing the pain patients once every 2 weeks, or for maybe an hour or something along that line. Sometimes we can see people a couple times a week, and there's a lot of time in between the cheerleading to really educate people about what's going on with you. Because if you understand what's going on with you, there's a lot less anxiety that's related to it. Increasing activity. Increasing activity is everything. If you become inactive, you're going to suffer more. I think everybody's touched on that. And finally, a part that's maybe not always talked about too much is that we can modify movements and postures so that they cause less pain. I'm going to briefly just buzz through this education stuff because so many people have talked about these things, but I think the concept of central sensitization is so important for therapists to be familiar with. It's not one we're taught much about in school, and I think it really helps to inform patients about why does everybody think I'm crazy? Why do I think I'm crazy? There's nothing wrong. Well, there are things that could easily have changed in your brain that are causing all this, and it oftentimes makes it a lot easier to deal with when people understand that there's something physical, rather than it's just a psychological factor. The importance of the psychology consult. I think every single person with chronic pain should see a psychologist. I think I think we're way off when we say this person has a psychological problem with dealing with chronic pain. Everybody would have a psychological problem with dealing with chronic pain. We're not made to deal with chronic pain, and I think anytime those resources are available, I think it's a real shame to miss that. Finally, the need for increased activity. There's tons and tons and tons of data about how important exercise is. People need to understand how important this is to improving quality of life, and we go through all this stuff in great detail with people at the level that they can understand. Now, just understanding about increasing activity and increasing activity are very different things. When you change a health behavior, there's a lot involved in getting that done. And so that's where you really need a professional in there that can say, where is this person at right now? How much can they do? And how can we get to the level of activity that's going to really improve their quality of life? exercise is the best medicine. I think we all know that. There's a great deal of information to back this up. I think it was C. Everett Koop, but one of the past Surgeon Generals said if 30 minutes of exercise was a pill, it'd outsell everything else by multiple times. And it's just the problem is we have to do it. And but as far as exercise goes, specifically with chronic pain, it helps with the effects of chronic stress. It helps with depression, anxiety. It decreases chronic pain, improves energy and endurance and attention. These are all huge goals for people with chronic pain. If any of these things can happen for somebody with chronic pain, you need to have them happen. It's so often underestimated how simple exercise can make improvement. But exercise is the best medicine if you can maintain the habit. And I think that's the big but. Looking out at this room of very healthy healthcare practitioners, there's probably still not that many more than 15% of us that are getting the recommended daily allowance. That's what it is. We all know it's important, but yet we don't tend to do it. And so how do you get somebody that it hurts when they do it to do it? And I just think it's worth taking a minute to think, would you keep up the exercise habit if it made you feel worse? I think so often it's turned around and it's like, these people are not doing what we told them to do. Well, if it really hurts, I'm not sure if I would either. And I think, the people with chronic pain are going to have pain. It's important that you pass that message along. But increases in pain that occur because of their exercise, that's something altogether different. And I think very often we get into this idea of, see, I told you to do this exercise, now you go out and do it. And I don't want to hear how it's hurting you. But I think that's really unjust to people that are suffering. And so I think that we need to take a look at, is there anything that we can do better than that? Here's just kind of makes light of that. You've got athlete's foot, tennis elbow, runner's knee, and swimmer's cramp. What you need is exercise. Well, what is the right amount of exercise? I think that the right amount is 30 minutes of moderate intensity aerobic exercise 5 days a week, and that's the goal I shoot for. I think it's really easy to think, well, these people, they have pain, they can't do that. Let's hope for anything. Let's just kind of take exercise as a dose-response relationship, just like medications do. And I think that you can underdose it. And if you want to get the benefits as far as improving anxiety, depression, improving quality of life, I think you really need to work at getting that activity increased. But does it matter exactly how you get it? It really doesn't. Do people have to walk? Well, if walking hurts them, no, they don't have to walk. They can ride a bike. They can walk on a treadmill. They can do any number of things. And that's where a professional that's really focused in on, look, I don't care how you get it done. Let's just find a way to get it done, can really help that process. I think a good simple example is spinal stenosis. Spinal stenosis, a basic issue with spinal stenosis is when you're in an upright position and the spinal foramen narrow, the pain can go up, the weakness can go up in the legs. Well, do those people then no longer have a need for exercise? Well, of course they have a need for exercise. But is it a good idea to encourage them to go out and walk even if their legs are extremely painful when they're done, or when are numb when they're done? I'm not so sure about that. How about having people walk while they lean on a treadmill, or ride a bike in positions that improve the mechanics of their spine and decrease their pain? Really, the key element in activity is habit. If you get a habit and you can keep it up, and you keep it up 5 days a week, 12 months a year, it's guaranteed to improve your quality of life. I mean, I feel so completely confident about this. The difficulty is the habit. And if you feel depressed and anxious and you hurt you hurt an awful lot, and as you go to exercise, you feel worse. It's so easy to just get out of that habit. I think that's where we can come in and do it. Now, habits, this boom-bust cycling, this idea of, well, people, they realize, I need to exercise, I need to, and they go out and they push hard, and crash. And then for 3 or 4 days or 2 weeks, they don't exercise. Well, that's a guaranteed way not to establish a habit. And I think with a therapist that's really tuned to these ideas, we can say, look, let's do 5 minutes at a time. Let's check it off a list. 4 times a day, we're going to do 5 minutes. And then 6 minutes. Can you do 6 minutes? Can we do 7 minutes? And it's a process. It doesn't happen overnight, but so it is. Otherwise, it just doesn't get done. And people 5 years from now, 10 years from now, have become less and less active. Now, when I finished up my doctoral work in physical therapy, I read an awful lot of papers about the sphere avoidance model of chronic musculoskeletal pain, and so I can't really pass up talking about it a little bit. But it's kind of interesting because this is a cognitive behavioral model, and it's really the primary model out there in the literature that talks about how do we increase our activity. How should people? How do we push people to increase their activity that have chronic pain? And so any understanding of how to move forward with increasing activity for people with chronic pain has to go through this model, because there's more research out about this than anything else. Yeah, essentially, the idea is this: is that if this model here, it describes that if you think that something is going to cause you pain, you tend to avoid doing it. Well, the reason a lot of people think something is going to cause pain is because it has caused them pain. Oftentimes that little detail is forgotten, and it's turned around, and the patient is blamed for well, you're fearful. Well, fear is a pretty normal reaction to pain, and oftentimes that's the reason that occurs. But regardless, that's a small point, and the main treatment and the treatment that in a lot of physical therapy programs for chronic pain is based on this model, is activity quotas. So you find out what this person has difficulty doing, what this person with chronic pain is fearful of confronting. For example, I don't want to I can't walk in the store. I can't go to the store because if I walk around, it's going to cause so much pain. And then you gradually work up on a quota system. You say, well, okay, this week we're going to walk 50 feet, and next week we're going to walk 100 feet, and next week we're going to walk 200 feet. And well, one thing is it works. It's a good idea. The research says it works to some extent. And just in summary, what this research says is that probably I think the starting point for a physical therapist that works with chronic pain is this: is that you need to understand that if you increase the fear of movement in your patients, you can make their lives worse, and this is that first cause no harm problem here. You don't want to increase the problem, and so who's going to induce a fear of movement in their patients? Well, normally with physical therapy, in acute and subacute injuries, it's very common to say, oh look, your ankle hurts. Well, don't do that. Stop doing that. Don't do those things that hurt. And so that's a common response. We have to be a lot more careful when we say those things. because the patient needs to understand that wait, there's a lot to this here. You've got to, first off, keep moving. Then try to be careful about avoiding excess pain, okay? Increasing activity is essential. That's something else confirmed. But like I said here, this graded exposure to activities by quota does help treat fear. It does help reduce disability. So there is some improvement here, but is it the best we can do? And my background and the background in physical therapy is a biomechanical one. We learn all about how the muscles of the joints interact with how motor control affects this, and yet when we come into chronic pain, oftentimes we're told, well, ignore all that. That doesn't have anything to do with anything anymore because this person has chronic pain. It's just psychosocial stuff. Well, I think that's easy for us to say sometimes and hard for them to accept, and I think for good reasons. I think perhaps a better way to look at things, and some interesting research that has come out in just the last couple of years is dealing with this concept of physical self-efficacy instead of fear. And really, physical therapists, although we can carry out this program that says, okay, increase your activity, don't worry about it, just keep pushing through. We can do that, but if it doesn't work, we're kind of out of tricks as far as it comes to treating fear, right? We don't learn anything about fear. It's really not something we cover. We learn an awful lot about self-efficacy, physical self-efficacy. Like how can you, let's say you can't walk a half a mile. How might you be able to walk a half mile? Let's say you can't pick up that box. How might you be able to pick up that box? That's something we can do. Well, some interesting research in just the last couple of years suggests that this might be an even greater factor than fear at leading to disability. And if we can address these issues, people can oftentimes benefit even more than if we just address fear. I think this is some important research, and I don't think it's gotten enough attention yet. Now, specifically, I thought this was just a very interesting quote, because from the physical therapy side of things, I'm all about movement. I'm interested in movement. I think it's all important. But this is from Alan Bosbaum. And he's the and excuse me if I got his name wrong, but he's the editor of the journal Pain, a longtime researcher in the neurophysiology of pain, and this is out of a chapter in a review of the last 25 years of pain and where we've gone, where we're going. The major clinical problem is not ongoing pain, but mechanical hypersensitivity. It hurts when I move. You know, I hear so oftentimes people say, you know, chronic pain, it's not like acute pain. There's no adaptive value to it. And I think, like a lot of broad statements we make, sometimes it misses something. And I think the point it misses is this. Sometimes we get into our head, somebody with chronic pain, they've got 8 out of 10 pain, 24 hours a day. Well, that's not the patient I see. The patient I see has pain that ranges from a 2 to an 8. When they do certain things like get out of their chair, roll over in bed, wake up in the morning, their pain is extraordinarily high. Sometimes it's not so bad. Well, you know, it'll be nice someday when we have the medications that can get in and deal with mechanical hypersensitivity, but the best thing we've got going right now is education on how to change mechanics, and that's where physical therapists come in. I'd really like to talk for a long time on how we go about doing this. Linda Van Dillen at Washington University in St. Louis, and where I went to, is doing a multi-million-dollar NIH study right now. And the first time where they've looked at low back pain and classified it on as far as movement classification systems, and followed it out for 5 years and seen what works best. And I use their approach to examination and treatment, but basically we're trying to find out what are the kind of physical stresses that cause problems. And if we can determine what kind of the physical stresses there are, we can teach people how to do it differently, especially the directional aspect of stresses. If extension stresses to the low back cause pain, well, how can you stop that with the movements that you make? If twisting stresses cause you pain, well, how do you do things different? That sort of thing. This all helps you to teach control of pain. Now we are back to improving sleep. And as far as one of these pearls, I think it's so underestimated how much sleep can be changed by physical therapy. And I'll tell you, if we could have a billboard that said, if you have a lot of pain when you sleep, try a pillow under your side, I think it would be a money well spent, because when somebody comes in to the clinic and they're, let's say 70 years old, a woman who has a wide pelvis and a narrow waist and sleeps on their side. Now, over 70 years, their spine has degenerated, and they lay on their side, and their side comes down to the bed. Now, they're bent like this. Now, let's say you had arthritis in your finger, and you did this, and held it there for 3 hours. It would hurt, and that's what happens to people when they sleep. The really very interesting thing about this, and that takes some skill, is that people have tried just about everything to improve their sleep, and they don't believe you at all that there's anything that can be done to improve it. So you really have to show them. It's very interesting when you've been up and about and you have a lot of pain and you go to lay down, you're gonna feel better. You get all the weight off of you, you're gonna feel better for 5 minutes, 10 minutes, 15 minutes, depends. After that, that's when the problem sets in. And it's hard to think, well, maybe it has something to do with the position I'm in at that point. And I think so you really have to work through this with people. And I'll often spend 45 minutes just working on improving sleep with people. And I've had so many people come back and say, you know, the best thing that anybody's ever done for me in the last 10 years is you've shown me how to sleep, and because now I can sleep. And it's simple, but I'll tell you what, 10 years ago, I wouldn't spend 45 minutes with somebody. I had to do something, you know, I had to do something, do a technique or do something to make them get better. Well, that's not what's really called for. Similarly, comfort with prolonged positioning. If you can't sit and you can't sit and play bingo with your friends, you probably aren't going to. And oftentimes, very small changes in how people sit can make very large differences in their pain. Finally, just simple things like getting in and out of bed. I wish I could get into some of the details of what we do, but getting in and out of bed, getting in and out of a chair, you can do a great deal to decrease the mechanical stresses in your spine by changing the way you get up and down. I'll just leave it at that. And again, if anybody has any specific questions about these, please feel free to email me. I love this subject, and I'll go on forever and when I'm given time. So the issues are sleeping, sitting, standing, getting out of bed, rolling in bed, walking, driving, all of the basic boring things that we all have to do to get through our lives. And if physical therapists don't help with it, well, who's going to help with it? I don't know anybody that I've come up with in my work, at least, that addresses these things in depth, and I think they require in-depth analysis. When you try to get people to change things they're doing, you have to be specific. If you say, well, just try to do this stuff and I hope it works, it doesn't work. You have to be specific, and I think the skill of providing very specific interventions for the person at hand is what gives you better relief. I think that well, I lost my train of thought there, so I'll just keep it. the last thing is that functional goals to help guide treatment. I think no matter what setting you're in, no matter where you're at, no matter where you practice, physicians see patients and follow patients for many, many years, and I think they're aware of things that us as physical therapists might not be able to pick up meeting somebody for a short period of time. It's so helpful to have a physician that can say, look, this person was sleeping fine and now they're having trouble. Is there anything that we can do? This person can't get out of bed. I think adding those suggestions in with your prescriptions is extremely helpful. Thanks.
Our final speaker for the afternoon before the question and answer session is Dr. Patrick Galvis. Dr. Galvis is a physician in Great Falls who is a physiatrist, I guess, by trade. Today he runs the integrative healthcare clinic over in Great Falls, and he's going to talk to us a little bit about the role of integrative therapies and how they may help chronic pain patients. So, Dr. Galvis, I'm going to let you.
Okay, my name is Pat Galvis. I'm a physiatrist practicing in Great Falls, Montana. We have a clinic, multi-specialty, 3 physical therapists that utilize strain, counter-strain, muscle energy, cranial, sacral, and myofascial techniques. I'm a physiatrist trained at Emory. We have a chiropractor, we have an acupuncturist, and we have a massage therapist. And there is usually one talk at a conference. It's usually the last talk. It's the fringy woo-woo talk. You get the picture? All righty. Okay, we're going to begin. There's our clinic. When humor hits the newspaper, you can tell things are getting mainstream. The newspaper is what, 5th grade reading level? And when the general public begins to understand this joke, we know that certain things are actually transitioning into mainstream medicine, and I love this particular one. Unfortunately, now we also have alternative illnesses like past life bursitis, leaky aura, pseudokarma, and feldspar deficiency. We don't treat those, however, with narcotics, thankfully. So, by history, in 1990, about 34% of the U.S. population used, quote, unconventional therapies. By 97, it rose to 42%. And then in 92, the NIH established the Office of Alternative Medicine with a $2 million budget. In 98, the name was changed to the Center for Complementary and Alternative Medicine with a $50 million budget. That name change is a paradigm shift in thinking, I think, of classic medicine and also of the government. Thinking, interesting. Anyway, we also hit this, my own specialty, complementary therapies and physical medicine and rehab, 1999, August. I attended this conference, evidence-based alternative medicine, in 1999. This was published, articles out of the major medical JAMA and the archive journals on alternative medicine. And this is coming into it. Now, this is very interesting, and I encourage my patients to utilize whatever spiritual help they use with their pain. Evidence-based studies, double-blind controlled study, prayer for people in the ICU. Lower length of stay, less complications. I mean double-blind. Physician doesn't know, patient doesn't know they're being prayed for. That's spooky. We got to look at that. All right. My Native Americans, I encourage them. Don Fish in Great Falls is a substance abuse counselor, Native American. He does sweats for these patients. And I encourage them to go. Use whatever your culture helps you with to help you cope with this particular problem. Manual medicine is old. This is a sketch of Hippocrates' machine for spinal alignment. All right, interesting. This is off a Thai temple, that's not kinky, to an osteopath. That is a SI joint mobilization technique. That's 500 BC. All right. In deference to Andrew Taylor Still and David Palmer, manual medicine has been around for thousands of years. In fact, there is rumor that Still and Palmer learned the techniques from Native Americans. And there is one quote by Osler, the father of internal medicine, that admonishing the physicians in Europe to learn what the bone setters do. Because if they can treat somebody after you say there's no help, you're in trouble. Your reputation goes down the tubes. There is an international movement. I attended this conference on integrative manual medicine in 2001 in Chicago. The Scandinavians are doing a lot of good studies on manual medicine. And what was interesting, parallel evolution of techniques. The Germans, I went to this one conference on one of their manual techniques, and this guy gets up on this lumbar patient. He said, this is the Fluten technique. And I look and I said, that's a modified lumbar roll. You know, two different medicines with evolution, parallel evolution on techniques on treating things. Now, we're throwing around visceral and somatic. How many of you really know what that means? My former life as a graduate student in anatomy at Southwestern Medical School, neuroanatomy, and here we are looking at the cranial nerves and the components, SSE, special somatic efferents or afferents, and general visceral efferents and all that, and I go to one of the professors and I say, why is the striated musculature, the mandible, the masseter, why is that's striated? Why is that visceral? Well, because it's innervated by the trigeminal nerve. Okay, well, why is the trigeminal nerve a visceral? Well, because it comes and it innervates these visceral muscles. And I'm going like, oh, this is going to get me nowhere. So I went to one of my professors, Gaylord Throckmorton. Now, your folks have condemned you to be an anatomist with that name. And Gaylord was one hell of an anatomist. And actually, he was looking at cranial kinesis in lizards, iguanids versus the varanids. Their joints, the sutures, move. And to an osteopath, that's kind of intriguing when you start talking about cranial sacral stuff. Well, anyway, he said, Pat, I need you to do me a favor. I want you to go to the departmental library, and I want you to read an article in Evolutionary Biology by Alfred Sherwood Romer. And I read it, and I gleaned a lot from it, and I have gleaned a lot more since being a physiatrist and treating pain. So, with thanks to Gaylord and apologies to Alfred Sherwood, we will take a little trip. The vertebrates are the only animals that have somatic and visceral. You see it in no other family. Well, why is that? Well, if phylogeny recapitulates or ontogeny recapitulates phylogeny. Honey, you're the speech therapist, give me a hand. We look at the vertebrate family tree. And when we come up, you'll see something kind of go off to the right, and it's called tunicates, or water bears. Interesting vertebrate. In the adult stage on the right, they have a mouth, a pharynx, a gut, and an anal pore. They have a gland, a nerve ganglion, and they have reproductive organs. And they are sessile. They sit on the bottom. Very visceral. You ladies have seen this Monday night watching football with a remote in its hand on your couch. An interesting thing happens in the larval stage. It grows a notochord and a whole new set of muscles. So we've got two things now. It's a composite animal. This is a biological advantage because you can imagine you can now detach yourself and swim somewhere looking for food. You're not sessile all the time. So some vertebrate decided, you know what, I'm going to keep that thing. And what we wind up with is that. And there is the visceral animal and the somatic animal in an amalgam. It's an incomplete weld because you can kind of dissect it out. So when we talk about medicine and we talk about somatic and visceral, this is what we're talking about. And we are looking at two animals. A visceral animal with a visceral nervous system, the autonomic nervous system, visceral muscles, and a visceral skeleton. The lower brain case, the sphenoid, the mandible, are visceral bones. They come from the trigeminal arch. They come from the facial arch. And then we're also talking about a somatic animal with a cerebrum and a cerebellum and a spinal cord and striated muscles and somatic bones. What's interesting also is the two nervous systems communicate. There are intraneuronal connections. Consequently, pathology in one can manifest itself in the other. In the osteopathic physician, we call that a visceral somatic reflex or a somatovisceral reflex. They can talk. Consequently, when you have a gastric ulcer and you palpate over here, there's a little bead and there's a tender point on your soma. All right? Somebody was just telling me this. Doc, you may think I'm crazy, but God, when I do this, it kind of helps. Yeah. And we can treat that with a little acupressure. Okay? So, let's look now at that somatic animal. It is segmented. Cervical, thoracic, lumbar, sacral, coccygeal. Each one of those levels has a nervous system, a nerve, a C2 nerve, a C3 nerve. It has a structure called a dermatome, which will give rise to skin and hair at that level. It has a sclerotome that gives rise to the bone and the joint capsules at that level. And it has a myotome, which gives rise to the muscles at that level. Hence, you have a C5 nerve. You have C5 muscles, the deltoid and the biceps. And you have C5 joints, the AC joint and the glenohumeral joint. The clavicle, its distal portion also. So that these structures, if you have pathology in the C5 disc, it can radiate pain to the shoulder, to the skin. God, Doc, this is funny, it's numb. Is it really numb or does it feel funny? Well, I can feel it. It feels just kind of funny. Tom Dorman, orthopedic medicine in England, calls that nulliness. I'm a homophobe. I call it pseudo-numbness. Okay? I can't quite say nulliness. You know, I don't wear salmon. It's pink. I don't give a damn what that people say. Okay? All right. So we go through, and this is true throughout the skeletal system. Now it gets a little freaky with the development of the limbs and the rotation. But if we put ourselves in the quadrupedal position, you can see the dermatomes and you can see how it's segmented all the way down. The face is not somatic, that's visceral, that's by the trigeminal nerve. You remember the ophthalmic, maxillary, and mandibular divisions. And we're going to talk about that a little bit later. This is the normal skin distribution. This is our dermatomal distribution. All right? Now, I said bones are innervated. And here they are, okay? These did not come out, I know, on your handouts very well. If you email me, I'll email you the whole presentation if you think it's useful. If not, I've got a disc and you can burn it here also. But recall that bones are also innervated, and consequently, a C5 disc will also radiate to the scapula. Right? C5 disc presents as burning between the shoulder blades, and the patients will tell you that. Okay. It also triggers a cervicogenic headache. All right. Here's the myotome. I'm a lumper. All right. C5 biceps and deltoid, C6 wrist extensors, C7 triceps, C8 long finger flexors, T1 intrinsic hand. You can do that on your musculoskeletal neuro exam real quick. All right. In the lower extremity, hip flexors, hip extensors, quadriceps, hamstring, anterior and posterior tibial muscles. Okay, you can do that real quick. So now, this is the basis for all this referred pain. The osteopaths call this the facilitated segment. When we have pathology, there are interneuronal connections to the somatic structures as well as the visceral structures, and that becomes activated. And the whole principle then of all this referred pain is that any pathology from one system can refer to the other, or to other structures that have evolved from the same somite, same sclerotome, same myotome, same dermatome. Manipulation, we think, probably works on the Golgi tendon apparatus and the neuromuscular spindles. Neuromuscular spindles are interesting. My whole PhD thesis was on the distribution of neuromuscular spindles and myofiber types. My wife got so bored reading that thing, and she still rants and raves about it. Not all muscles have the same fiber types because of different functions. They also, when I looked at the intertransverse serrae muscles, are very rich in spindles. In fact, they are very complex spindles. Fran Richmond and Abrams looked at them in the neck, found the same thing. These are probably sensing devices. They're not prime movers. They're sensing devices for the greater vertebral type of muscles. And they allow us, and probably by our either high velocity, low amplitude, the crunch that with chiropractors and osteopaths do, or more gentle techniques of myofascial release and strain counter strain, we influence the spindles and we influence the tendons. When you're graduate students, you'll do anything for money. We did one experiment at Southwestern where we hold a grip, we were holding a grip strength, and then vibrating the biceps tendon. You can't hold on, you release because of the input onto the tendons, the Golgi tendons. This is a very elegant experiment by Core at Kirksville, a professor of physiology. He took individuals and took x-rays and had them aligned. And then he shimmed one of the ischial tuberosities to put them out of alignment. All right? Then he did ESR on them. And look, this is what happens with the one on the left is normal. The one in the middle, you shim and wait about 18 minutes, and you see now skin resistance changes. And when you pull the shim out, and you do it about 18 minutes later and look at it, it's back to normal. It's showing that somatic dysfunction, as we call it, can influence other structures. So when your patients start telling you stuff that sounds weird, they very well may be giving you, like the one physician said, they don't know anatomy, so you better know it. Because the symptoms and complaints they are giving you, they are trying to tell you what's wrong. But they can't come in and say, my T3 is rotated right a little bit, and I've got this somatic dysfunction. No, it hurts. Okay? Here's some discogenic pain radiating to the scapula. If you look at that previous on the scapula, scapula comes from C4, C5, and C6. And these are just pain radiations from a disc going into the scapula. Facet pain, dermatomal, radiating in these areas, again, 4, 5. So now we have another sclerotome, but it's radiating to a dermatome at the same level. Okay, lumbar, back pain. Big money. I forget how many millions of dollars, was it billion now we're spending in back pain. The classic. Radicular pain. It's a no-brainer, right? You got to radiate, you got a herniated disc, pushing on a nerve, they come give you the distribution and you do it. But what do you do when you do the MRI and there's no herniated disc? It's pain specialist. My God.
You know they're lying down.
No, they have to be. They're secondary gain. No. Let's go one step. A disc can have annular tears in it. The annulus is innervated. Substances, and moreover, the disc does not have a blood supply. It relies on a pumping motion to bring the nutrients in and expel the metabolic products. If it isn't working, if it's desiccated, if it has an annular tear, they not only got the innervation from the ring, they're getting metabolic products also that are causing pain. We call it discogenic pain or axial pain. It's real. They will give you a quote dermatomal distribution, but because the disc is innervated by the nerve above and below, it's a blend of those dermatomal patterns. And it's not true numbness. It's pseudo-numbness. You mean you can't feel this? No, I can feel it, doc. It just feels funny. Okay, pseudo-numbness. They're giving you that distribution. The same thing is true of the facets, facetogenic pain. The capsule is innervated, nerve above, nerve below. It gives you a blend again. So look at the report, forget about, okay, so you've ruled out the herniated disc, but now see what else. Is the disc desiccated? Is there some facet pathology? If there is, we can do some other things. Traction trial by PT. Discs will respond. It'll play hell on the facets, but that's part of your differential. They come back and, man, it made this worse. Okay, I think then probably it's facetogenic pain, and we're going to take a little bit better technique. Okay, acupuncture. Great. Acupuncture works. The effects, the analgesic effects of acupuncture is blocked by naloxone. We use the endorphin and enkephalin system. We think it's somehow related to the central processing. We don't know for sure. Some of the meridians will coincide with some of the peripheral nerves coming out. And I'll show you that a little bit later. Also, French group was doing some stuff where some of the meridians they thought coincided to where fascial planes come together, which is an interesting thing. Fascia is alive. It's not the stuff you used to throw in a bucket in gross anatomy. It is living tissue. It has mast cells in it. Fibroblasts contract. It is capable of becoming a pain generator. Sacroiliac joint, the bane of my existence. It happens in disease states like pregnancy. Thank you. It's not a laughing matter if you get it. And I've had patients, it typically, the first kid, it's toward the end of the delivery. With each successive one, the pain comes on sooner. And it is bad. I mean, they cry. There are some structures you can use. One of the PTs found kind of like a thing to pull this up and give them some support. You can do some SI support with it and treat. SI joint injections can be effective. Acupuncture would be worth it, a try. Mobilization techniques that are very gentle are worth it from physical therapy or chiropractic. All right. Typically characterized by pain with the dance. Stretch their leg out, sitting on the good side with the other one out. Okay? Palpation tenderness to the posterior superior iliac spine, and you walk your thumb down the SI and it's ooh, ooh, ooh. Standing and seated forward bending tests. Osteopathic secret, I'll show you. Can I have a, somebody please do it? Oh, come here, honey. Okay. Simple thing, any primary position. You stand up, you put your hands on the iliac crest, you hook under the posterior superior iliac spines. You have them slowly bend forward. Your thumbs, go ahead, your thumbs should ride up equally. Okay? If it doesn't, you've got a problem. So what you do With this particular test, you have three alternatives. SI joint dysfunction, tight hamstrings, short leg. So what do? Well, I'm sorry. You get a stool. So you take the leg out. You do that very simple. You have to sit on a stool. Wait. Thank you. Spread your legs. Sit down. Go forward. Now you've eliminated the leg. So if it rides up, it's SI joint dysfunction. If it doesn't ride up, then you're faced with an anatomical or functional short leg, or a tight hamstring. Okay. Now you can, if it's anatomical, you can get a scanogram. You can actually measure it with X-ray. 5 minutes a month, robust stretch. Okay. Sorry. All right. You can do that. Muscle spindles cause pain. We talked about spasm. Techniques involved with physical therapy, probably, again, myofascial release, strain, counter-strain, muscle energy. Those spindles can be causing pain. You don't have to give them a drug. You can try some other techniques. Acupuncture also would be a good one. All right, here's the visceral. If you look on these, you'll see T1 through T4 are the heart levels. Okay, and it goes through the kidney. I pass kidney stones. All right, I can tell you where they're going. And the reason I can is because the pain will hit. As it comes out of the pelvis, it hits a stricture, and the pain will be here. And then it will travel down, and there's a narrowing in the ureter, and when it hits that, I feel the pain here. Then, right before it goes into the bladder, there's another stricture, and the bladder is down in the sacral area, so I feel it into the testicle. Female's going to get it into the labia, right before it goes in. That's that visceral somatic. The pain is in the viscous, but it's transmitting itself to the soma. All right? Here's your road map. All right? It's the autonomic nervous system. You pair it off. There are afferents with this thing. They taught us it's a strictly motor system. No, there are visceral afferents. They follow this same pattern. All right? Cancer pain is exquisite because organs that have a capsule don't like to be expanded. Just like when you get a little sliver in your finger where the septate trap, all the edema, you wonder, why does this hurt so much? 3 minutes, okay. When you smack your finger and blood gets trapped under your nail, you get that hot paper clip to relieve it, okay? Visceral organs are sensitive to stretch. It makes sense because stretch causes rupture. They do not go through the lateral spinal thalamic tract. It's through vagal afferents of stretch. So visceral pain is a little bit different. And you get to know that, and you have to know that. All right. Here are some common referred areas for different visceral organs. This is actually out of Guyton. All right. Same here. All right. Autonomic pain. There are autonomic dermatomes. The autonomic fibers are not only located in the peripheral nerves, they travel along the great vessels. And consequently, you will get pain in a different distribution. Thermography is wonderful. It's had a bad rap. But you can use it for complex regional pain because it doesn't depend upon the hot phase or the cold phase. It will show both. And if you can look at this and the observer says, well, you know, that's following this particular distribution, they've got complex regional pain syndrome. Here is the lower sympathetic. This comes out of Haymaker and Woodall, a great peripheral neurology book. This is showing now a dermatome that again in lower extremity is autonomic. These are Chapman's reflex points. There are, Chapman's an osteopath. These are superficial points on the soma that you can treat certain visceral conditions with. When I was passing kidney stones in medical school, my classmates would treat me by going and giving me relief on those points using acupressure. It does work. You females, once a month, what do with your back pain? Is your pain back here? No, it's the uterus. Where does the uterus come from? S2, 3, 4. What are you doing? You're putting your thumb on that sacral area, and it helps relieve it. Here's the dermatome, and if you look at the acupuncture meridians, you can kind of coincide with those that are parasternal, those points. So we think kind of that that's what's going on. Trigeminal nerve, fifth cranial nerve. It goes everywhere. It is the nerve of head pain. It innervates the jaw, the TMJ, okay? It innervates the muscles of mastication. It innervates the face. Doc, you may think I'm crazy, but when I have a headache, my hair hurts. Really? Where? Here or here? Here. Stuff back here? No, this is C2, C3. This is women, big, nice hair. Time to get a haircut because they start having headaches. They'll tell you that. I've had patients say, you know, when I start getting headaches, I get my hair cut, and the headaches go away. All right? Sinus distribution. Here's the connection between the cervical structures and the trigeminal and the base for cervicogenic headache. All right? Injury to the ligaments, the disc, back here in the neck will trigger a cervicogenic headache. Okay? You can help a cervicogenic headache with a TENS unit. You have to cut down those little things and put them right over where the supraorbital nerve is, and you can place one back here. Acupuncture works also. You can do the greater occipital nerve blocks, but you can use some other stuff. The ear, interesting structure, the ear. The reason I looked at it, one, people will say, Doc, my ear, something's wrong, look in here with my headache. The upper portion of the external canal is by the trigeminal, the lower portion is by the vagus, the upper portion of the tympanic membrane is by the trigeminal, the lower portion is by vagus, on the inside it's glossopharyngeal. So, I saw this and I thought this is a bunch of bull. And I said, no, Pat, come on, let's go back. Okay, the ear comes from 6 auricular hillocks. The innervation of the external portion is by trigeminal, C2 and C3. The facial nerve, the glossopharyngeal and the vagus are right in here, which coincides to those points of the lungs and the gut on those acupuncture points. Interestingly, one acupuncture point for a headache is located right here, which is the supraorbital nerve. All right. So there are the visceral bones, and that's a little craniosacral talking about the sphenovascular mechanism. And I love Michelangelo. I'm still learning too.
Okay, so if the speakers would come up and field any questions, well, yeah, come right on up if there's any questions, because we sort of shortchanged you on the end. Yes, sir.
Questions for Dr. Davis. Dr. Davis, could you kind enough to explain the two oddball terms on page 4? One looks like it's maybe alexithymia, the other looks like it's ergomania.
Yeah, sure. Well, I'm taking a question, so I'll take it. How about that? Alexithymia refers to difficulty or inability to experience emotional states. And according to a theory advanced quite some time ago now, there was the idea that some people may experience increased physical pain as a substitute for the emotional pain that they're unable to experience. Every once in a while you may run into a patient who just, you know, far more out of touch with their emotions than the average husband is. And so it's a theory and something to look at. I don't know if there's any scientific validation of that, but it's a psychodynamic theory that was advanced, I think, back in the 50s, perhaps by Engel or his colleagues. And then ergomania is a similar older psychodynamic perspective on chronic pain, which holds that people stay very physically busy all of the time as a way of keeping awareness of unpleasant mental content out, keeping it repressed or suppressed. And that when they have an injury or an illness of some sort that prevents them from engaging in this sort of ongoing quasi-manic kind of activity, that those that suppressed or repressed mental content then threatens to emerge into consciousness. And so a person may focus on pain or in some kind of psychodynamic way convert that emotional pain into physical pain.
Thank you.
You're welcome.
And then on page 2, you have down at the bottom there
Something about my question is regarding fibromyalgia. At the bottom of page 2, you talk about Gurje's, G-U-R-J-E, study on pain, and said that the likelihood of the psychiatric diagnosis is associated with the number of pain complaints. Well, patients with fibromyalgia complain of pain in multiple places. Does this relate to the patient with fibromyalgia too, in terms of the psychiatric status?
And I don't know how to respond to that question. I'm afraid I can't answer that without pulling out the article and reading it really carefully. I'm not sure if it has, off the top of my head, I'm not sure if they address that issue or not.
Well, you normally think of a patient with fibromyalgia as having significant psychiatric illness.
Do I? Not necessarily.
Yeah, this is to the whole panel. What are the historical and physical findings that differentiate nociceptive from neuropathic pain? And another question for Dr. Junker, what physical findings do you have on piriformis syndrome? Then my third question is, what is the deal with the weather? Does it really affect pain? I don't believe it.
There's actually a Canadian study with that, and it's pretty consistent that certain patients do have weather trophy. I don't know what it, but
What's the mechanism?
I have no idea. They looked at this with headaches, I believe, and there was a correlation with the weather pattern and headaches.
I tell people all the time that if I ever figure out why they've become walking barometers when they have chronic pain, they can come over and help me polish my Nobel anytime. We really don't know. But since we know now that bones are innervated, that discs are innervated, that tissues are subjected to mechanical stresses of all kinds, maybe even pressure changes have something to do with it. Someone with fibromyalgia, it's not just their toe that can tell you a hurricane's coming, it's everything they've got. Nociceptive versus neuropathic. Key issue, and the best way to do it, I think, is to talk about neuropathic pain. You're looking for dysfunction of the central nervous system. So when there is abnormality that's consistent with that, for example, allodynia, hypersensitivity, hyperalgesia, more pain than you should have, and you're looking at it in different modalities. You don't just check it to light touch. We do our exams, our neuropathic pain exams, we use light touch, cold, warmth, vibration, position sense, von Frey hairs. We check everything out and look at all the different modalities, because that'll help us figure out, is there small fiber dysfunction, is there large fiber dysfunction, or is there central dysfunction? We look at the distribution of the pain. Does it correlate with a particular area of damage, like pain, dysesthesia, sensory impairment out in the periphery, feet and hands for peripheral neuropathy, or particular radicular distribution or peripheral nerve distribution corresponding there. So neuropathic pain, we're looking for very specific findings that indicate something's the matter with the nervous system. Central pain syndromes, hemibody pain after a stroke, band of pain or pain below the level of injury in a spinal cord injured patient. So those are the sorts of things that we're looking for. Whereas for nociceptive pain, although none of this is exclusive by any means. It's rare to find a pure condition. But for nociceptive pain, people are complaining of different things, and you're not seeing disturbances of sensation as much as just discomfort. Anybody want to pitch in with that?
No, I don't have anything more to add to that. I think that was excellent. As far as the question on the piriformis syndrome, probably my physiatry colleague could answer things better than I can in that situation. But for me, generally, pain on palpation of the sciatic notch, and you can get redistribution of pain. And I believe there's several names of different tests that you can do. I forget the exact names. You guys would...
Wouldn't you be able to externally rotate?
External rotation, usually having the leg straight and externally rotate can usually reproduce the pain, yeah.
When you have them laid out on the exam table, you'll see the one leg flops over. You can resist some stuff. Palpation, they're tender right in that area. You can feel a knot many times.
Yeah.
And usually they will tell you.
Those are the general ways, and then you can get a pelvic MRI, and sometimes an MRI. You ask your radiologist to look at the piriformis muscle, compare the sides, and sometimes you'll see atrophy on the one side, but they can sometimes pick it up on an MRI also.
Yeah, if you just think about the pathophysiology, anything that puts the piriformis on stretch and would tend to tighten or irritate the sciatic. So if you internally rotate the foot, or if you make them contract the piriformis muscle. So if you resist, so if you have somebody lay on their back, put their leg over their knee, and then have them try to externally rotate the knee, the leg, they use the piriformis to do that. So it's going to tighten it down. They're going to feel that pain on the sciatic nerve, and then they're going to get that sciatic pain or that sciatica. So that's the way I think about it. I don't think about it in terms of test as much as the physiology I'm trying to reproduce. And there's lots of ways to do that.
Right.
How common is it?
How common? That's difficult, because I think that for a long time in the orthopedic literature, people denied it existed. And then all of a sudden people started saying, well, yeah, maybe it does exist. So it's one of these controversial syndromes that a lot of people still deny exist. And if you talk to people, they'll deny it exists. It's an entrapment neuropathy that, I have begged the MRI scan people to start doing neurography with the 3 Tesla scanner, because what I really want to see in thoracic outlet syndrome and things like piriformis, I want to see an objective picture, because that's the way we think. And the minute we get something that is hard evidence, like, showing somebody where you can point and say, look at that, look at that, look at that, look at that little squeezed hose right there, then they'll believe it.
Yeah. And just to confuse the picture, you can have piriformis pain without sciatica, by all means, and you have to be careful to differentiate it from sacroiliac joint dysfunction. Right. And you can do it if you really know your exam. Our interventionist, when she brings people in with an outside referral for SI joint injection, she'll always take a look at them, and she'll do that SI, but if she doesn't get a good analgesic response, she'll go and she'll do a piriformis injection under fluoro while she's in there, and she'll usually knock it down. If it didn't work with one, it'll work with the other.
Thank you.
Any other burning questions before we break?
I have 2 quick questions. First one is in terms of the Medicaid program. So this is statewide?
Yes, it is.
So if I have a Medicaid patient, I can have them call and set them up?
Absolutely. And you can call as a provider and ask them to be put on the program. We'll look into it and see if there's a diagnosis. Sometimes people have been seen multiple times and they keep getting the diagnosis code put through as hypertension, even though you're seeing them for their back pain, but you've never coded it as such, so they don't come onto the system. You can ask to be put on, ask the Medicaid to put them on the system.
So in other words, if you code it right, they will automatically be contacted?
Well, remember you have to have several visits for it and other things. So we still want referrals in because the provider knows really whether or not they would benefit from the program.
And my other question is sort of generally for the panel. My experience with a lot of my patients are different strokes for different folks. And some of them really respond to acupuncture, and some people really respond to standard physical therapy, craniosacral massage, Any thoughts about that, or any ideas about who responds to various different kinds of therapy?
Well,
Those that aren't on narcotics will respond better to acupuncture, and the acupuncturists will tell you that. If they can catch them before they're on narcotics, they respond better, because we're going through the same pathway. If a patient tells you, Doc, if you could just pop it, it'd feel better, that's a no-brainer for chiropractic or some physical therapy with a mobility a mobilization technique. The others, I think,
it's how you know the patient. You fly by feel, really. You look at where they are psychologically, you look at what their coping level is, you look at what they're ready to do, and how much you think they can tolerate. I see people that I know, the only thing I can do with them is a warm water pool and a psychological evaluation. And that's about all they're going to be able to handle to begin with, and we can gradually move them up after that. I think it's telling, by the way, that nowhere in the discussion this afternoon did anybody mention ultrasound, hot packs, cold packs, electrical stimulation, or automatic spinal decompression tables. And I think that's because, and appropriately, these are helpful modalities at times, but none of them is really that useful over the long haul as a definitive treatment for chronic pain. These folks really need a careful and individualized approach, and you need people who know the musculoskeletal system. You need physical therapists who have the background and the training to look at each person as an individual. So when you're choosing your physical therapists, if what they do is 10 minutes apiece, hot pack, stim, give them a sheet of exercises and send them home, your patient will not get better. Just like all the doctors do things differently, so do the PTs. And I really appreciate the emphasis I've seen here this evening.
Yeah, I would say that I always tell my patients, if the physical therapist that rehabbed your ACL, he's not the guy to do your chronic pain management. Different concept.
Yeah, could I just talk to that as far as with the physical therapy kind of stuff that I was talking about? I really think that the key there is, do they hurt when they move? Is the pain occur with certain movements? If it does, then there's ways to move different. In my ideal world, I would love to see people with chronic pain 2 to 4, 5 times a year on a regular basis, because I think life goes on, we degenerate. My mentor says, we're all falling apart, you better get used to it. It's the truth. I mean, there's nothing we can do to avoid that, and as we go through these changes, I think we always have to look at how we do things and see if we can do them better.
I just wanted to say I thought it was really interesting that only one of the panel mentioned sleep as an issue in dealing with chronic pain, because with the members that we see, it is across the board. Sleep is a huge problem. And I think if we don't address the sleep problems, we're never going to really make the progress with dealing with chronic pain. And I've read a lot of articles, I've done a lot of research on fibromyalgia, and have actually read that the sleep architecture is altered, that these people don't get into stage 3 and 4 non-REM restorative sleep. And I don't think sleep medicine has reached the point where we're really addressing sleep architecture and how to deal with that. I wondered, does the panel have any ideas on why this happens? Is it to do with the central nervous system hypersensitivity, that the sleep architecture is altered? Is it a hormonal result? And I have read about the drug Xyrem, and I wondered if the pharmacist could tell me. I know that is very controversial. It has been used in some research studies with fibromyalgia patients. Do you know anything about the drug and why it's not used more for chronic pain patients?
I didn't hear the name.
Sodium oxybate.
Xyrem.
No, I know that it's out there, but I don't know enough to actually discuss it. I'm sorry.
It's actually, the date rape drug, and so I know it's controversial because of the illegal use of it, and a lot of physicians will not prescribe it because they're afraid to. But I know with fibromyalgia patients, it's had wonderful results, far as helping them sleep and deal with that pain. But as far as the central nervous system, is that what alters the sleep architecture? Does anybody know?
There's an alteration in it's alpha delta sleep. I used to, about 1/3 of, I think it's 1/3 of people with fibromyalgia have a sleep problem, and I would send them for a sleep study because it's an objective finding, and the guy that used to read it to sleep medicine would say altered sleep pattern secondary to alpha delta intrusion, secondary to pain, which gave me an objective finding. We know that growth hormone is released during those periods of sleep that are disrupted, and growth hormone in the adult is for tissue repair. So it's kind of a vicious cycle. I don't know much exactly why the sleep pattern. Mohammed Yunus did some studies on college students, that's been years ago, where they would go through a sleep study and he would not let them get into restorative sleep.
Right.
And after a couple of weeks, they had all the trigger points of fibromyalgia. So there's something with that sleep pattern that's intimately connected.
And growth hormone and insulin-like growth factor 1 are diminished in people with fibromyalgia. And one reason for that may be sleep architecture problems. We still don't know entirely why it's so dysfunctional, but we also have to look, I think, carefully at iatrogenic causes of sleep dysfunction, because some of the things that we use, particularly the opioids, which give a lot of people twitches and restless legs at night, are things that can disrupt the sleep architecture even as we're trying to help the patient. And beyond that, with comorbid depression and anxiety, sleep is terribly disrupted, and sometimes you can restore that with adequate pharmacotherapy, get sleep back to a bit better baseline just by treating the depression and anxiety. But it's difficult. We talk about agents to restore sleep architecture. The tricyclics, wonderful drugs, but very difficult to tolerate for a lot of people. The benzodiazepines and the modified benzodiazepines, they work, but after a while you can't sleep without them. I've been trying out baclofen and tizanidine as nighttime agents because they do provide some pain relief and they are mildly sedative, and some people find those useful. And we use a lot of sleep studies to see what's going on with the patients. But many of the treatments are, as you say, we haven't advanced that far yet. And a lot of these people you can't put on a CPAP. Give somebody with, PTSD a CPAP machine, it doesn't work very well. Oxybate, I have a couple of people on it. I'm not prescribing it myself. I'm not afraid of it, but I don't really know how to use it properly. The couple of folks who've had just horrendous sleep problems have said that it actually is quite helpful for them. We just have a very small cadre of doctors who know what to do with it, and I think as that grows, we'll be starting to see it used more often.
In a general term about sleep, I think that it's not an oversight necessarily, it's just we didn't have time to add a sleep thing. I think all pain physicians are becoming acutely aware at how important sleep is. In our own pain clinic, we utilize a sleep doctor constantly, and now we finally enticed him to actually come and not necessarily join our group, but to become much more engaged in our discussions and our collaboration. So I think you're going to see more and more and more attention directed towards sleep. And I would finish by saying one other thing. I think that one of the issues that becomes more and more clear to me, and one of my pet peeves, is that we start with a system that is the human system that is so far out of whack, that's been perturbed, and our first response as allopathic physicians is do something that perturbs it more, rather than try to look at things that may result in less perturbation of the system and allow the system to reestablish a self-managed homeostasis. And for me, that's the key, is to see if I can first look for an intervention that really promotes a return to homeostasis rather than continuing to throw these huge opiates and things like that are going to further perturb the system. So I'm a big proponent for minimalist interventions that allow the system to regain some sort of balance.
If I can just follow up on that, because I think it's been my experience that it just is so underestimated, the simple changes in mechanics how it can affect sleep. I see so many patients that have been to therapy for months and months and months with many therapists, and they haven't addressed those basic issues. And I know one issue that comes out in the basic science of fibromyalgia is there's where they call it the temporal summation of pain, where a little tap, tap, tap normally feels like a tap, tap, tap to most people, but it feels like ever increasing pain to somebody with fibromyalgia. Well, if you lay in a position and there's a mechanical stress there and that builds up over time, that's going to build up much faster for somebody with fibromyalgia. I think it's just that we just haven't taken the time to look at it. Now, part of this is because it's so difficult to study, and nobody makes money off of it. There's no drug money, you know, it's like when you show people how to sleep better, you help that person, but there's no profit. And I think that's, yeah, I mean, I hate to be cynical, but...
Talk is cheap, right?
Yeah, right, exactly.
Maybe the Sealy Posturepedic guy.
Right.
By the way, temporal summation is a cardinal feature of neuropathic pain, which ought to tell you something about the pathogenesis of fibromyalgia.
I think it's also a cardinal feature of the Chinese water torture.
Thirsty?
Well, no, I sort of have a question too. Sleep is also a factor with weight and obesity. I mean, it is very important. And I find that people get anxious. There's so much anxiety involved with the fact that they cannot sleep, besides the positional factors. What about melatonin? Anybody have?
Who wants to tackle melatonin?
Well, I'm great.
Before you start, just let me tell you that we got to get out of this room really soon, so keep your hands.
Okay, this will be the last question.
Okay, melatonin, they get it from cow brains. The end. No. And you don't know whose brain you're dealing with, so you got to watch out. But beyond that, certainly does help restore sleep architecture. Not a miracle drug by any means. They've gone out and built Ramelteon, which is a melatonin receptor agonist that costs like $8 million a dose, but apparently is helpful. Key things to know about melatonin are that it is a hormone and it does have estrogenic properties. Melatonin plus progesterone is an effective oral contraceptive sold overseas. So when you're giving people melatonin, you're giving them hormone replacement, and you've got to watch what you're doing there. You've got to look for thromboembolic complications, particularly in smokers. You've got to look for feminization in men. You've got to watch your stuff with this, your step with the stuff. That said, you know, we've seen it be helpful, but I think you also have to take a very hard look at what the primary causes are of the sleep dysfunction in the first place and see if you can remedy those, or no matter what pill you throw in there, it's not going to make much of a dent. And the safety data are still not really out there for the use of health food store melatonin.
Okay, so two things. One, I guess be back for the reception at 6, and we will start the panel this evening over dinner at 6:30.